Very good evening. Am I heard? Are my slides visible?
Yes, yes.
Yeah. A very good evening to one and all of you. And my very special thanks to Dr. Mahipal, Dr. Namrata, and Dr. Rajesh for having me here again with you all. The most important thing here, what is this special feature about corona and glaucoma? Basically, much of what I'm going to talk is something which you're all familiar with. You've been hearing any number of webinars. But I think that extra compassion, that extra sensitization as far as our dear glaucoma patients is concerned should be of great wealth and use for us. What we need to remember as I start my talk is one of the members of our fraternity from Wuhan in China was a glaucomatologist. He was very well protected and yet was lost his life to this disease while examining a glaucoma patient. The importance for us to understand is as ophthalmologists and as ENT surgeons, we tend to be very much closer to our patients. We're exposed to tears and much more, and we need to be wary about this disease. A quick update, we all know it's a single-strand RNA virus, could present as a follicular conjunctivitis, is known to spread through the respiratory route, fomites, and query fecal-oral route. The asymptomatic carriers are about whom we need to be really wary of. And of course, any amount of protection of environmental contamination could be said any number of times and stressed. The basic outline of management continues to be the same. We need to ensure continuity of care, a very strict administrative control, triage, personal and patient protection. And till this lockdown is over, only emergency surgeries and a very gradual transition to the other surgeries. The reason why we talk about glaucoma patients again is because this is a very vulnerable age group. They have varied level of anxiety on a day-to-day basis when we have seen them because of their visual debilitation. So what is mandatory is that we should pull out the list of all our glaucoma appointments over the next couple of months, send a full large-scale SMS to them. Besides that, spend time on a telephonic counseling separately with these glaucoma patients and tell them why we are going to stagger the appointments and tell them that we should avoid unnecessary routine visits the next few months because we really care that they come back to us again and again over the years. We should use this opportunity. Any window is necessary with these patients who are older and forgetful. We should discuss their medications, collecting drugs from our hospitals, and we should tell them to be receptive to the fact that there might be alternate prescriptions as long as they are the same formulations. It does not matter over the time period. We should use this opportunity to reiterate on the application schedule, washing of hands, the punctal occlusion, and tell them that they need to visit us only if there is an apparent emergency. We need to guide them on fixing the appointments because they tend to be quite forgetful. Somehow glaucoma and age and forgetfulness go hand in hand. We would promise them that there's going to be a minimal waiting time, but we should warn them that there is going to be certain personal protections which are going to be mandatory during the visit. We'll promise them that we're going to stock all the glaucoma medications in abundance in our respective hospitals, and reassurance, reassurance, and reassurance is going to be a mantra with this dear lot. Some of us have already faced the first day post-op and the first few days in our early days of lockdown. So we must have already told them that we are going to minimize their post-op appointments, and very few would have at all needed a digital massage, maybe an extreme situation. Probably even releasable sutures with the intraocular pressures are in single digits, lower digits. Probably we should do away with it because we do not have OT sterilized instruments and we may have to rely on an instrument sterilizer. We should tell them about hand wash, of course, the distancing, social distancing, wearing of masks, protective gear, and tell us only if there is a drop in vision, some redness, and some more pain. What we could do is we could top up the steroid drops a little longer duration, greater frequency, because we are no way going to be doing needling or 5FU procedures to take care of those early bleb fibrosis cases. And we should use this opportunity to tell them that they should be using medicines in the unoperated eye. As far as the administrative control is concerned, that is the mantra now which we have to follow. We have to emphasize to these glaucoma patients that there is going to be a greater need of virtual visits, teleconferencing. We should tell them that do not come back to us unnecessarily in the next couple of months or more. We could supplement it with generous loads of SMS information, educative materials, a very energetic, very helpful helpline, and ensure that there are enough of drug-free refills in our hospital. Of course, personal protection must have been told to us any number of times in the last couple of weeks by our AIOS leaders. So we need to do all of it, the infrared the thermometers, the history taking, which is so very critical. And any amount of emphasis on this does not go waste. And of course, personal protection, even more so because we're going to be so much closer to these patients. We have to tell them that they bring in one attender. We have to allow that because these are our older patients. And we would tell them that all of them have those strict regulations at the entry point, and a very efficient triage is needed, especially we decide when we do gonio, when we check the pressure, when we do the fields, and no dilatation for a while to come. If there is more space, we should allow a separate seating arrangement for our glaucoma patients. And believe me, intraocular pressure cannot be a mandate for a while. What we should do is, we should look up the history, the records of these patients before we call them in. Chitra, and we should not be checking the intraocular pressure.
Chitra,
we should not check.
We should check louder.
We should not. Okay, can you hear me?
Yeah, we can hear you a little louder, please. Huh?
Yeah, we should check the intraocular pressure. Need not check the intraocular pressure for a well-controlled patients, as we've been seeing them earlier on. We should check IOP only for our post-op patients. And new patients where the optic disc evaluation tells us there's something more sinister hidden, do we check the intraocular pressure? Or if it's a shallow anterior chamber or with acute onset of symptoms. Again, gonio is going to be very extremely specific, only for shallow anterior chambers and acute angle closure glaucomas. Fields also would be for only very advanced glaucoma patients or where we need to clinch the stage of the disease, and that would bring on a change in our management, or poorly controlled intraocular pressure patients. And what our senior optometrist specific to the glaucoma clinic should do is, he should keep getting in touch with us at different points of concern to take a call as to what investigation is going to be done, and we have to avoid dilatation. Probably the triage to decide on intraocular pressure could be a recent onset of eye pain, a recent onset of redness, or a recent onset of hair loss, besides all that I alluded to. Educative information is the mantra for the next few months with these patients. We have to have signages about information on respiratory hygiene, cough etiquettes. We have to have educative SMS and mails. We have to have signages so that they go directly to the drugstore and need not come to the reception unnecessarily. Signages at the restrooms for a proper hygiene, and instructions at the entry point is all absolutely mandatory. We should seat them on alternate chairs. And as I said earlier, keep a separate waiting area for the glaucoma patients with well-ventilated area. Of course, a very good cleaning of the surrounds, and this would definitely give confidence to our patients. And we should not allow them to line up at the reception desk at any point. We should remember that the conjunctiva and tears are a known source of virus transmission. So we need to avoid all aerosol generating procedures, which means we have to avoid NCT, because a tear film dehiscence and aerosol formation does happen here, for which we could use Goldman applanation tonometers or even an iCare tonometer. And we should clean the tips of the applanation tonometers with isopropyl alcohol between two patients. Again, I'm sure all of us are already doing it. Install a screen guard in our slit lamps. Keep well away from these patients. Use protective glasses, more so when you're evaluating your glaucoma patients, because we're going to be doing a 90D. No gonio, feels absolutely necessary only, and that too we would have to clean the headrest and the chin rest of these perimeters. So what we have to do is avoid talking to the patients at the slit lamp, but please, we need to talk to these glaucoma patients. We sit afar from them after we finish the evaluation, transfer all confidence measures to them. Keep remembering they are a vulnerable age group. All of us keep hearing 60 plus have to be careful. And people, some of the youngsters have even decided that they could do away with the generation, which is not to be done. Every single individual is precious for us. We should tell them that we are going to stagger their next appointment and definitely use alcohol rub between patients. Personal protection is so very strongly recommended for our glaucoma patients. When you're taking care of them, surgical hand wash, Even our MLOP should be wearing gloves because we tend to interact closer with these patients of ours, and disinfectant sprays or even mobile HEPA units should be considered. So when do we take these patients to the OR? It would be if it's a lens-induced glaucoma, angle closure glaucoma, uncontrolled secondary or primary glaucoma, acute lens complications, catastrophic or rapidly progressive glaucomas, uncontrolled intraocular pressure, endophthalmitis, corneal touch, corneal decompensation, or an exposed plate. In the OR, definitely a PPE is needed, is what I believe, although there is a controversy whether PPE is needed in an ophthalmic unit at all. No general anesthesia as far as possible because it is aerosol generating. Keep minimal staff, and I would even mask the patient. Finally, it's most important for us to remember again and again that is a very vulnerable group of patients. They are distressed, they are anxious, they need our psychological support in abundance. And believe me, I think we need to treasure this lot because they are our only major consistent bank of dear old patients who keep coming back to us in 3 months, 4 months, and 5 months. And we need to live to see all of them for any number of years. So that's why
Audio is gone.
Can you hear me?
Yes, now it's clear. Now it's clear.
You heard most of it?
You have to be loud. You have to be speaking loudly. So Chitra, can you give the last message?
Yeah, so the last message here is that corona is a dreaded disease, but when it comes to our glaucoma patients, any amount of care is definitely worth mentioning. Any amount of caution is necessary. Thank you very much.
Thank you, Chitra. Tanuj, would you want to say something on that?
I think Dr. Chitra has very nicely highlighted the tips regarding management of glaucoma patients. There is just one issue regarding the guidelines for sterilization of tonometers. So the American Academy of Ophthalmology came out with a guideline that if you want to kill all the viruses, including adenovirus, then the best chemical to use is sodium hypochlorite. So if you use the alcohol spawn, some amount of adenovirus can still remain. So for a complete sterilization, it is better to use 1:10 diluted sodium hypochlorite solution. There are some questions for Dr. Chitra. The first question is from Dr. Pawan Kumar Jain. Can corona present as conjunctivitis?
That's how it was very strongly thought in the initial days, but it's not necessarily so at all now, from what we understand. But I think it is an evolving disease, and there's so much more of changes which keep coming in. So we're really not sure about that. But yes, a conjunctivitis patient, I think all of us have been so primed that we would definitely take them separately and evaluate them and not allow them to mix with the general lot.
I think there is some data that, if you have a COVID positive patient, 1 to 3% of them can have a conjunctivitis. So what you said is absolutely true. You have to avoid doing an NCT because that can generate an aerosol, and preferably use a applanation Goldman tonometer or a rebound tonometer and use a separate tip for each patient. There's one more question that is regarding if you have patients scheduled for perimetry and OCT, especially elderly patients, should they be called right now or should they be asked to wait?
Definitely, you should ask them to wait, but of course, you would look at the records. You would find out at which stage of glaucoma disease they are, and then reassure them, because all along we've been insisting on fields and OCTs to these patients. So we are going to be talking a different language suddenly. So we need to spend that extra time and explain to them that it's for their protection. We are changing the routine.
Yeah, and one more thing, if a patient has a shallow AC and you're not able to do gonioscopy and patient has a high intraocular pressure, your laser is not functional or that is closed, then maybe additional pilocarpine can be added for some time till your routine laser procedures are active and you can do iridotomy. So that can tide over this period. Then the one last question is for Dr. Chitra, how to clean or sterilize your perimetry machine?
I think you would have to, you can't do anything to the bowl. You can only clean the chin rest and the headrest. That is all you can do.
I think it is better to defer doing perimetry at
Yeah.
this stage.
Yes. Yes.
Any comments from Dr. Barun Nayak?
No, Miss, whatever she said is absolutely right. And only thing that all the procedures try to avoid, because, but then also emphasize, because every time we have been telling so many fields should be done and should be repeated. But at this point in time, it's better to slightly defer the appointment and call those patients a little later date. And the perimetry, as well as even everyone is scared in recording intraocular pressure these days, because you are going so close to the patients that the tonometer head is touching the patient's eye, and the rebound tonometer is not very practical, because every time you have to use a different the probe in that, because that probe you have to throw it off, because it goes and comes in contact with the patient's cornea. So that has to be discarded every time. But one suggestion which came, I don't know how far it is practical. Those who have got tono pen probably can use, if you have got enough cap over the head, then every time you use a tono pen and discard the cap over the head of the tono pen.
I think,
I just had one query. When we clean the this biprism with the sodium hypochlorite, after that you have to dip it in the saline for some time.
Yes, ideally you should soak for at least 10 minutes.
Okay. I think there's some questions related to conjunctivitis, and it says, can we have a pure COVID conjunctivitis? So there are no cases of pure COVID conjunctivitis which have been reported so far. Another question is, can acyclovir eye drops be effective for recent conjunctivitis, which is due to COVID? Or I don't think acyclovir has a role to play in COVID conjunctivitis or otherwise in any kind of conjunctivitis. And then what is the shelf life of 1:10 sodium hypochlorite solution?